Hello guys, welcome to today's case. So today we have a man in his 40s presenting to the ER with confusion, and it's given in his past medical history that he is a diabetic type 2. So formulating the differential diagnosis for this case, the top one would be non-ketotic hyperosmolar state, which is more prevalent in type 2 diabetes mellitus. Second, we must consider the metabolic causes. First one would be renal failure. My apologies. I put there in parentheses renal failure. That should be because of type 2 diabetes. As you know, it can cause renal failure. And this other metabolic cause would be hyper or hyponatremia, or it could be hypercalcemia, which can be due to cancer or parathyroid hormone level increase. And last but not the least, we must also consider infection as the precipitating factor. So our next step would be to do some labs. Okay, so let's formulate our initial diagnostic plan for the case. First and foremost, we must get a basic metabolic panel. We should also order a CBC, urine analysis, a chest x-ray, a lumbar puncture, and a tox screen. Now all these are very important to rule things in and rule things out. BMP. So for this patient, it gives us a glucose level of more than 900. Now such a high glucose level is common in hyperosmolar non-ketotic coma, especially which is associated with type 2 diabetes mellitus, and rest of his blood work was normal. Also consider that in older patients, silent ischemia is also a possibility which needs to be checked out. So for that, let's move on to our further diagnostic plan. We need to do an EKG to look for any ischemia, and also any changes to the EKG in other patients because of osmolar disturbance and electrolyte disturbances. We must also get a blood culture and a urine culture, looking for infectious causes in this patient. And we should also move this patient to the ICU because patient needs continuous monitoring, which is not very easy to do in the ER. Okay, so coming on to the treatment plan. This patient needs a lot of fluids, IVF. This is probably the most important part of his acute treatment plan. Insulin does help in this condition, but not so much as it would help someone with type 1 diabetes mellitus, because this patient already has insulin resistance. Of course, you should give insulin to these patients as well. Okay, so once the acute episode is over, we should also treat the patient long term. So first and foremost, the drug of choice is metformin. It has its side effects, like lactic acidosis, but you need to be careful around that, especially in someone with renal failure or renal insufficiency. Second, you can try sulfonylureas, which increase the insulin production, drugs like glipizide, glyburide, and lastly, the glitazones are good drugs if you're running out of options. Remember to keep checking his glycosylated hemoglobin A1 level, and also put him on diet and exercise. Thank you guys. See you next time.